talk. But I'll talk about the surgical tips for doing well-cemented stems. I think we need to challenge some of the things that you've just said. This is the National Joint Registry in the UK, the largest joint registry in the world, lots of cases. If you look at the blue line, the amount of uncemented is going down, and it's been going down for the last 10 years. What's going up, the orange line, are the number of hybrid hips. So obviously the hybrid hips are a cemented stem, but we've also kept a number of cemented cases as well. About between 25 and 30% are totally cemented. So in the UK, the use of cement is more common than the use of an uncemented stem. So I think it's really important to look at it. And the reason we're doing that in the UK is because people are reflecting on the results and having a look at it. And we have improvement programs in the UK, such as the Getting It Right First Time program, which makes people look at money as well, and hopefully gets to somewhere where Crawford is talking about people making the right moral decisions. So in the UK, cement is on the increase, not the decrease. Now, what we do know about cement is if you improve the technique, you get better results. You can make it better, last longer. And we've seen that lots from all the Scandinavian literature. And of course, it's a bit of a no-brainer. You know, the better you do something, the more attention to detail, the more likely it is that your long-term results are going to be better. When people swap from cement to uncemented hips, they often sort of look at the results from many, many years ago and say things haven't improved. Actually, cemented results have improved proportionally even better than uncemented results because, as Ross says, it's really impossible. Well, not impossible. It's much easier to do a good and better cemented implant than an uncemented implant. Of course, the stems themselves have changed. So Ross was talking about the Exeter stem, the sort of evolution we've seen at Wrightington from the sort of Charnley stems to the C stem, resulting in sort of polished, tapered stems, which have produced better results. And with great long-term results with cemented joint replacement, and with the use of maybe different plastics in the socket, increase the longevity still further, going to cross-linking cemented polyethylene. So, okay, about the tips and techniques. So I did a trochanteric approach. I took the trochanter off until about 12 years ago, and I then changed to a posterior approach. Not minimally invasive, because I want to be able to see what I'm doing. There's no point trying to do an operation that you want to last 30, 40 years through a really small incision if you can't really fix it well. And I would argue that you want to be able to have exposure to see. I don't mean do an enormous incision. I mean to have access. And it's quite interesting, of course, I find that the larger I make my skin incision, the less I have to cut inside. Some of the so-called minimally invasive surgeries mean that you have to do an awful lot of release of structures to actually deliver the femur through the wound. Where if you make a reasonable sized skin incision, you hardly have to divide any deeper structures at all to do your hip replacement. So in terms of the tricks and things about cementation, so in terms of when you do a cemented hip, a cemented acetabulum, this is, and I'll come back to cemented acetabuli, because actually cemented acetabuli are actually very unlikely to be revised, actually. So even though the hybrid hip, which is a cemented stem and an uncemented socket, is becoming very, very popular, actually, as Ross showed in his older patients, a cemented socket actually can work really quite well as well. So in terms of sizing, you need to have some form of cement mantle, and tend to ream up to have maybe about 5 to 6 millimeter to my last reamer compared to the size of the socket, to give me about sort of maybe 3 millimeters or so of mantle. The thickness of the mantle is not as important as actually getting pressurization of getting the cement into the bone. I don't want to go below the subchondral plate. I do want to make lots of drill holes, and I prefer smaller drill holes, a large number of them, not going too deeply, but really to make sure the bone is completely clean and lavaged, making sure the anaesthetist is keeping the blood pressure low at the time of cementation. I personally prefer high viscosity cement, it's a lot easier to deal with, to get hold of, to put into the socket, and to use a pressurizer, silicone pressurizer, to force the cement into the bone. You use a flange socket to get further pressurization. And as I say, one of the long-term worries about has been socket wear, and using new plastics in the socket, I think, has further increased, has made the results better still. I like to use quite quick setting cement, not because of wanting to do lots of more cases in the day, but I don't want to be waiting for ages when there's the potential that the blood might bleed back, that the bone might bleed back to me. So I use a CMW2, a fast setting cement, which will set in probably about 5 minutes, maybe even just slightly quicker than that. I mix the cement, I introduce it into the acetabulum between 1.5 minutes. I pressurize it up to 3 minutes, getting good pressurization into the, forcing cement into the cancellous bone. Introduce the socket, and then I want the cement to set quite quick at that point, because I don't want to be stood there holding a socket with very soft cement, with there being blood accumulating in the bone cement interface. And I remove the excess cement at about 3 to 4 minutes, and it's set in about 5 minutes. And it's really not taking that long to do that. I've got lots of control over it. Sure, you're going to be careful of the ambient temperature and sort of issues about cement going off more quickly, which can talk about the minor technicalities, but it's very quick, it works well, and the cemented socket is unbelievably durable and works well, and you can put them in small patients. From the point of view of the stem, well, again, you need to have visualization and access to make sure that you're looking down the femur. You want to go through the piriform fossa. And what's important with the cemented stem is you put it right down the middle of the femur. You're not trying to use the fattest stem that's going to wedge in there, but you do want the tip of the stem to be in the middle of the medullary cavity. Certainly, I like to maybe over-rasp in terms of I like to create space to get the component in. I remove the loose cancellous bone, but the trick and the tip here is not to try to scrape out all of the cancellous bone down to smooth cortical bone, because at the end of the day, you want interdigitation of the cement with the bone, and therefore you need cancellous bone to be there. And very importantly, I think, with a cemented hip, that you close the canal. That helps you with pressurization, but it also reduces the chance of embolus, of fat embolus, of forcing blood and fat into the circulation, and cement monomer as well, to close off the cavity. So lots of lavage again. So lavage to remove all the debris, to get a good bed to cement in, but as I say, to also reduce the risk of maybe a cement reaction. I think cement reaction is very rare. I think that's more likely to be an embolic reaction of forcing fat into the bloodstream. And I think you can get that with an uncemented hip as well as with a cemented hip. Keep cleaning the femur. I introduce relatively high viscosity cement through a cement gun. Don't want to put the cement in too early. Again, for the same reason for the acetabulum, I don't want to be waiting around with the stem in the rehearsed position for ages, waiting for the cement to set. And if you have a bad mix of cement, if it doesn't feel right, it doesn't look right, then don't use it. Just put it to one side. Never use cement that you're not happy with if it's not been mixed properly or you're worried it's going off more quickly. So use a cement gun. Distally, it's obviously filling the distal femur first. Distally, you can allow the cement to push the gun back a little bit, but proximally, you've got to draw the gun back with the cement. And a really important trick, that what you don't want to end up doing is when you pull the nozzle of the gun out, is for you to pull the proximal cement out. Your good proximal pressurization, and I pressurize for a long time. I tend to use a cement for the femur, which will set in about sort of 9 minutes in total, 8 to 9 minutes. I don't take any longer than that. I'll sometimes even use fast setting cement in the femur if it's of a reasonable size. And you've got a lot of time once you've introduced the cement to gradually bring the femoral component up to the right position, to get the version right, to get the depth right. And there isn't a panic when you do this. You've got lots of time once you've put the cement in and pressurize it to bring the stem to the rehearsed position Whereas obviously with an uncemented stem, you're pretty well fixed where that's going to be. Whereas with a cemented stem, you've got a lot more time and variables in your control to put things exactly where you want. You're going to maintain pressure on the cement until it's fully cured. Remove the extruded cement. Just make sure you haven't forced cement where you don't want cement to be. And examine the socket at the end, that you've not got a blob of cement that's escaped from the femoral cementing that's going to interfere with your reduction. I think the use of the bone block, we like to use a bone block. Why pay for an expensive piece of plastic to put down to close the cavity? I mean, you can use gelatin blocks, but even then there are religious ramifications for those. Some of those are porcine materials. So we like to use a bone block. We introduce a bone block into the femoral stem and put the tip of the stem into it as we cement in. And it's cheap and it's reproducible and it works well. So, so why would I use anything else really but cement? So this is a sort of one of my cases, a CDH case. So on the right, you've got a fairly dysplastic hip, but I've been able to put a cemented hip in that side with a cemented socket. But the most important trick, you've got to be able to cover the socket. You can't have it uncovered, and you really want the top of the socket to come over the top of the cement. Cement isn't a glue, cement is cement, and it needs to be contained, and there needs to be superior containment. So on the right, I've achieved that. On the left, I've achieved that. Whereas on the right, obviously, that's a very dysplastic hip, very high center, and I've had to reconstruct the socket. And once you do that, the trick is to make the socket, so you've got bone all the way around, and you can cement into all of that. And the trick is to really to make a single construct at the end of the day, which is the socket, the cement going into the bone graft, as well as the host bone. And the anatomical deformity that you can manage with a cemented implants is enormous. And you don't have to force the patient, to fit your implant. Your implant with the cement, the composite effect, means you can cope with amazing variation. And certainly, in very difficult situations, multiple malignancy, you've got awfully deficient bone, where you'd really struggle to get initial primary fixation with an uncemented implant with lots of screws, where you can actually use cement. The trick being you're floating cement into a prepared acetabulum, forcing the cement into the bone, which gives you immediate intrinsic stability. I will mention revisions because I really think it's important. I think one of the biggest problems we have in this day and age is the over-engineered first revision. And once you've done that, once you've gone excessively long and you've burnt all of your bridges, you've used up all of your bone, and then you get loosening or worse still infection, you've got nowhere to go. And so I would argue that cement, particularly when used with bone graft, both in a primary situation, but particularly in a revision situation, means that you can have a durable construct, but it allows you to think about next time because you've restored bone. And just, the classic horror case, this was a very simple revision to do on the right. You could have just removed that stem, done an impaction grafting. But no, someone wanted to put a longer uncemented. As you see, they fractured the femur. They've then gone from that for an even longer component. That cut out, they've gone for a total femoral replacement. And to go from that, as a simple revision to that is completely disastrous. And by using cement, and by using very simple tricks and techniques, you can restore bone, restore anatomy, you can keep it simple, and you've got somewhere to go if there's a next time. So the tricks are, with cement, is don't necessarily go longer. You can go shorter. You don't have to go long. We've just reviewed that, just publishing it, that using shorter stems rather than longer stems at revision have not resulted in massive failures and periprosthetic fractures. The purpose of bone grafting, look at the femur here. So this femur has been treated with impaction grafting. Clearly, there is no point trying to cement into smooth cortical bone. And the purpose of impaction grafting isn't about restoring a lot of cortical bone. It's providing you with a rough surface, a surface you can cement into, that the cement can interdigitate with that. And if you look at those two, look at the femoral shaft there, you can see you've got a really nice looking cemented interface there, where the cement blends with the cortical bone, rather than trying to cement into a smooth, loose stem cortical cavity, which doesn't work well. So cement gets a bad name if it's not used properly, and using cement as a trick with bone grafting gives you a great result. And the same there on both sides, on the acetabular and femoral side. And we see lots of this, lots of femoral, acetabular revision is our commonest revisions that we do. And by using cement with impaction grafting, this is 6-7 years down the line, you can have a fantastic reconstruction. You've restored the bone, you're back into the primary situation. So the trick and the tip is not to go for large lumps of metal, not to go for jumbo sockets, but with contained defects to actually use bone graft. An acetabular revision with a cemented acetabular component with bone graft works exceptionally well and is very durable. These big cases here with a large central defect, again, without structural graft, with impaction grafting works well with cement. And I would only go long if necessary. And of course, with cement, you can put antibiotics in it. You can do a one-stage revision for deep infection, which is a fantastic way of dealing with a really unwell patient with one operation. And, one-stage revision for deep infection works really well. Why it's not been popular in the States, of course, is that people want to use an uncemented component at the end of the day. So they go to all that trouble of doing 2 operations just so they can use an uncemented component, when, as Russ has said, the results of an uncemented component are not as good as a cemented component in any case. So really, we need to challenge our thinking about what we're trying to achieve. And of course, acetabular reconstruction, when people have gone for jumbo sockets here, very simply converted to a structural bone graft here to give you some containment, a head graft with impaction grafting. And even with cases like this, you can do massive impaction grafting, cases that you'd really struggle with to deal in any other way apart from trying to replace half the hemipelvis, and you get amazing remodeling of the impacted bone. So really, with tricks and tips, I would be very prepared to use bone graft with cement to cope with bony defects. Again, back to the National Joint Registry, cement, whether it's totally cemented or hybrid, is working really well. It's the uncemented that's produced the poorer results, and hopefully we've seen the back of a lot of the metal on metal and other components that have failed. And whilst I agree with, Ross says that, well, yeah, he's talking mostly about the cemented femur, I wouldn't forget about the cemented acetabulum. If you look at the risk of revision of any femoral component, actually, a cemented socket is the least likely thing to be revised. So a cemented socket can work incredibly well. And it's just having the courage developing the techniques. And the techniques are quite simple to get a good cementation. And as I say, with crosslink with poly now as a cemented option, you're getting good long-term results. You don't have to use a metal back socket to use a crosslink poly. You can cement crosslink poly directly to bone. And there's a cost. As Ross has said, it's very cheap compared with a lot of other technologies, and the results are better. And there are actually not just 4 people involved, there's 5 people involved in the system, and it's often the government or the insurance company, the payer, is also involved. And in the UK, we're really recognising that the better results are produced by actually some of the more cheaper components, and that's important for society. So in conclusion, yes, there are little tricks and tips we can use, but I use a cemented hip in nearly every patient. Excellent published results. Registry data supports it. Registries are showing increased use now of cement. It copes brilliantly with anatomical variation. You don't get this long-term stress protection. An uncemented stem in a young patient is such a disaster if you're trying to revise that at 20 years when the bone has melted away, whereas you don't see that with a cemented stem. You get good loading of the bone and it's easy to revise. Cement works brilliantly with bone graft. I can treat infection with a one-stage revision. I fit the prosthesis to the patient, not the patient to the prosthesis. It's cost effective, and improve techniques to produce better results. And do you know something? It is absolutely not difficult to do. That's what Charnley was all about. You can teach someone how to do a really well cemented hip in a relatively short period of time. You can overcome people's nervousness about using cement. High viscosity cement's easier to use, and you can practice in the lab. You can practice your technique, and I honestly think that cement done well produces fantastic results, and you can all do it. Thank you very much indeed.